Hi, good afternoon. I'm Tyler Jacks. I'm president of Breakthrough Cancer, and I'd like to welcome you to Breaking Through, which is a live series. This is our second edition of Breaking Through, and we're going to talk today about a very important problem in cancer research, namely minimal residual disease. And we'll define what we're talking about in just a moment. I'm joined today by three investigators who are part of research teams funded by Breakthrough Cancer, all studying this important aspect of cancer. And I'd like them to introduce themselves first, and then we'll get into a discussion in a few moments. So if I can start with Jacqueline Garcia.
Hi, I'm Jacqueline Garcia at Dana-Farber Cancer Institute. I'm a clinical translational investigator in the division of leukemia. So what that means is I take care of patients with advanced leukemias, acute myeloid leukemia, I'll call that AML as a nickname, or myelodysplastic syndromes that are high risk, and help to design early phase clinical trials to offer patients innovative therapies. I'm also a part of the Breakthrough Cancer organization and one of the very happy funded recipients at our institute, where I serve on the Measurable Residual Disease, or MRD group, for the acute myeloid leukemia section of the grant.
Perfect, thank you. And Alice Shaw.
Yeah, hi everyone. I'm Alice. I'm a physician scientist. I'm a lung cancer doctor and researcher. I'm also chair of the Department of Medical Oncology at Dana-Farber and chief of strategic partnerships. And I'm a very proud member of the Breakthrough Cancer Powered to Cure ALK-positive lung cancer team lab. I've been studying oncogene-driven lung cancers actually for over 20 years, both in the lab and the clinic.
Wonderful. And finally, Amir Jazaeri.
Hi, everyone. It's a pleasure to be with you today. I'm a professor in Department of Gynecologic Oncology at MD Anderson Cancer Center. My areas of clinical interest are developing new immuno-oncology drugs for patients with gynecologic cancers with a focus on ovarian cancer. And I am also a proud member of BTC as part of the Ovarian Cancer Minimal Residual Disease Project.
Wonderful. And thanks again for being with us. I'm very much looking forward to our discussion. I'd like to start actually with a little bit of a framing. Some of those in our audience are perhaps less familiar with Breakthrough Cancer. So let me give you a bit of an introduction to the organization, and then we'll turn our attention to the topic of the day. So Breakthrough Cancer was formed not long ago in response to the pressing needs that we all recognize to make changes in difficult to treat cancers. Globally, 10 million people succumb to cancer each year. In this country, more than 600,000. We've made great progress, great strides in our ability to treat this disease, but still there's much more to be done. Probably everybody listening to us has known somebody, perhaps themselves, has faced the diagnosis of cancer. And this brings with it fear, anxiety, confusion, frustration. And frankly, that frustration is really what's behind all of our motivation to do more and to do more quickly. We were formed following a pledge, a very sizable pledge from Bill and Alice Goodwin and their families, who had been longstanding supporters of cancer research around the country at great cancer institutions, at MIT, at Dana-Farber, at MD Anderson, at Memorial Sloan Kettering, and at Johns Hopkins. And they'd been supporting research at these institutions for really a couple of decades. They were satisfied with the work that was being done with their financial support, but frankly, they thought we could do more. And specifically, they thought we could do more if we acted more collaboratively, if we worked more effectively together. And they challenged the leadership of these institutions with this opportunity to create something new, to do things differently, to collaborate across disciplines, to bring individuals who don't normally work together, speak together, plan together, to tackle some of the most challenging problems in cancer. And as such, this organization was born. We take an approach which we think is quite distinctive. We've dubbed this approach radical collaboration. Collaboration that cuts across, as I said, disciplines, brings individuals from different institutions together, brings scientists and clinicians, data scientists and engineers onto the same team, inspires them to think together, to plan together, to work together, and to approach problems in a very focused fashion, where the focus of the effort is on progress. It's not on the next research paper. It's not on personal accolades. Rather, it's on progress for patients. And that's really the watchword for all that we do here at Breakthrough Cancer. Over time, we focused on 6 different cancers: glioblastoma, pancreas cancer, ovarian cancer, acute myeloid leukemia, ALK-positive lung cancer, and most recently, osteosarcoma. And each of these diseases is challenging in their own right, but they share a common feature, which is that all too frequently, patients develop recurrence to their treatment or to their disease. And the rates of their survival rates for these diseases are often unacceptably low. To date, we have launched 10 teams tackling these cancers. And as I said, they bring together a diverse range of talented individuals, all committed to working differently, collaboratively, to tackle the problem collectively. Each team, as I said, co-develops their ideas. They share data in real time. They share credit as discoveries are made. This is a model that demands trust amongst the individuals who are participating, transparency, and urgency. Now, we at Breakthrough Cancer are not passive. We're not just funders. We actually work closely with the teams to monitor their progress, measure their progress, and indeed help them overcome challenges that they might face as they pursue these important projects together. And as such, we have the opportunity to hear about their progress at some frequency. And the progress has been quite amazing, actually. Even in the few short years that we've funded these teams, really wonderful things have happened. And we're going to hear about some of that today. And it was because of our excitement of hearing about this progress that we decided that we would bring it to you in real time, if you will, to hear from the investigators directly about what they're doing and what they're learning and their excitement about what lies ahead. So today we've decided to discuss minimal residual disease. This is sometimes called measurable residual disease, sometimes called molecular residual disease. We'll use the term MRD to describe all of that. And for simplicity, what we're talking about here is the state of the disease that exists after treatment, perhaps successful treatment. Perhaps the patient has gone into remission. And then a process of waiting ensues, where the patient might undergo scans over time to see whether the disease remains in remission. And the hope, of course, is that it does, and forever, and the patient is cured. But unfortunately, all too often, the scan reveals that the tumor has returned and eventually presents in the form of relapse. And what we'd like to understand collectively is that state of the disease that exists at the time of remission. We know that for many patients, there are cancer cells there because they do eventually come back. But we need to know more about them. We need to know how to track them. We need to know how to target them. And we need to think about new clinical strategies that focus on them as a way to accelerate our ability to control this disease more effectively and more durably. And that's what I want to talk about today with my colleagues. So let's get started. I'm going to throw out a question, and maybe Amir, I'll ask you to begin, just to make sure that we're all on the same page. So when we say minimal residual disease or MRD, how are you thinking about it? And how in your practice are you detecting it? How do you know that somebody has it?
Yeah, so I was smiling when you said that the M in MRD could mean so many different things, and I think this sort of highlights the fact that MRD is evolving, and it's probably not just one thing in all cancers. I think sort of an interesting thing about our view of MRD is in ovarian cancer, typically assessment of disease is done with CT scans and a tumor marker called CA-125. After patients finish frontline treatment, Many times, as Tyler mentioned, they achieve remission, which means the cancer becomes clinically undetectable. So CA-125 is normal, CT scan has gone back to normal. And yet we know that many patients, unfortunately in ovarian cancer, the majority will experience a recurrence. And when we talk to our patients and when we say that the cancer comes back, of course, it doesn't really come back. It's that it never leaves the body. And so some number of years ago, we started to sort of borrow from historical use of surgery in ovarian cancer and start offering patients at the end of treatment a outpatient, minimally invasive procedure called second look laparoscopy. And so this is literally a surgery where we make small incisions. We put our camera through one of the incisions. We do multiple biopsies throughout the areas in the abdomen where ovarian cancer has a propensity to hide. And all of this material goes to a pathologist. The pathologist examines all of the biopsies under the microscope. And so often when we can find cancer that's so small that we don't even detect it during surgery, we have to rely on our pathology colleagues to let us know if it's present or not. And so that became surgical minimal residual disease, if you would, in ovarian cancer. At the same time, of course, there was the revolution of circulating tumor DNA and other liquid biopsy technologies. And so now we have the opportunity to compare surgical MRD with molecular or circulating tumor DNA MRD. All of this to just highlight that MRD is not one thing, and probably the disease context is really important. But I think there's also some shared features that I think the audience will hear as we continue our discussion.
Yeah. Yeah, terrific. Jacqueline, let me turn to you. In hematological malignancies, the measurement of residual disease is more routinely done. Can you talk about how you pursue this question in the context of AML?
Yes. So I think I'll start by sharing with how I think about measurable residual disease, or MRD. And I think about it as what we can't see and what can eventually be trouble if not addressed. And so one of the analogies I have found to be really useful that I did not coin, but a lot of us have shared, is the iceberg analogy, where we know what we could see above the surface of the water, and that's the disease at which we treat, and we look for a remission under the microscope using bone marrow biopsies as a way to guide response or eradication of leukemia cells. However, what we know about icebergs is that much of the bulk or the mass of the iceberg is beneath the surface. And that's where therein lies the challenge for acute myeloid leukemia, where we have billions of blood cells in our body. And the idea and question is how much disease is truly left over? How do we measure it? How do we quantitate it? Which quantity is sufficient to represent a risk? And what is the quality of the biomarker? Are we able to distinguish what's normal versus abnormal, meaning what's normal blood gene versus an abnormal blood gene that represents risk for leukemia to return? And so in acute myeloid leukemia, it's been routine for us to obtain a flow cytometric biomarker assay to measure MRD at the end of an induction period. And induction means the first line therapy, whether it's intensive or less intensive. And how we use that biomarker is really the next challenging question. We all know that when you have leftover disease, despite remissions by eye, when I say that, it means under the microscope, it looks like you're having a response. But by the specialty testing, where we're able to identify 1 out of 1,000 cells, that we can identify one bad cell out of 1,000, we know that those patients represent a group that's at higher risk for disease relapse. And so we tend to escalate therapy at that time, offer them modified consolidation approaches, including consideration of something that comes with curable possibility, but also risk, and that's stem cell transplantation. So at this time, we are pretty routinely using this at all major leukemia centers. For those that treat leukemia in the community, they might not have access to it, but we do use a flow-based MRD assay. One of the challenges and also benefits of treating AML in 2025 is in the last decade, we've had nearly 10 drug approvals for AML, which is incredible because we now have more options. And that means a few things. AML is a disease of older age. For the most part, we definitely have young patients, but because it's a disease of older age, it means that what we used to give for treatment, which was intensive chemo, was not really an option for the majority of people. But with all these advances in therapies and approvals, we are now treating more patients than ever before. People that may have been just recommended for a palliative approach or a strategy that did not have a chance of a remission. We actually have more remission-inducing therapies. So we can now ask the question of, when do we stop these therapies? When do we now escalate and then transplant these patients of advanced age? And when could we potentially stop therapies? So that's how we're starting to use MRD in this current time.
Wonderful, thank you. And Alice, I know that in lung cancer, MRD is something that is routinely measured in certain contexts, but perhaps not in all. So put the MRD question in the context of lung cancer broadly, and then specifically in the case of ALK-positive lung cancer.
Yeah, so again, just like Jacqueline, I mean, just in terms of thinking about MRD, actually what Amir and Jacqueline were saying, a few of their phrases really resonated with me. Cells that never go away, or cells that we cannot see, because that is how we regard MRD, or minimal residual disease, these cancer cells that are surviving and persisting despite exposure to very active anti-cancer therapies, such as targeted therapies. And we often use the term drug tolerant persisters that really comprise this residual disease state. And these are lying dormant. They're not going anywhere initially, but then they do acquire some changes that allow them to start growing. And so I would say we often think of MRD as sort of this reservoir from which fully resistant cancer cells can eventually emerge. And of course, those resistant cells are a big problem. They drive the relapses in the clinic and really limit the benefit even of our best targeted therapies and immunotherapy. And so in terms of, measuring, tracking MRD, we do this, I would say routinely in lung cancer. I would say using often standard tests such as imaging. Amir mentioned, obviously CT scans are very commonly used to look at how much cancer remains after a patient's undergone treatment. We use CT scans, to get a good look at the anatomy. We may also incorporate PET scans. That gives us a different dimension of the disease in terms of, is there any metabolic activity associated with residual disease we might see? But I think, as we were all saying, I mean, these imaging modalities are really limited in terms of our ability to really truly assess MRD, especially when MRD is really microscopic in many of the cases. And so hence the need for much more sensitive assays, liquid biopsies to detect circulating tumor DNA. And here what we're really looking for are really small, even trace amounts of tumor-derived DNA in the bloodstream that could indicate the presence of residual disease. And so we use ctDNA then as a surrogate measure of MRD. And we are now, I would say, fairly routinely using ctDNA in lung cancer patients at the time of diagnosis. So if we first meet a patient who has what appears to be advanced lung cancer, we will actually send a liquid biopsy right at the beginning. We often will check a ctDNA during the course of treatment. And importantly, we check ctDNA, of course, if there are any signs of progression. And I would say, Tyler, in terms of your question around ALK, I think this is where, for ALK-positive lung cancer, so that's a type of lung cancer where we have activation of an oncogene called ALK that is driving the growth of the cancer, is really necessary for the survival of the cancer. And there we have incredibly effective targeted therapies that can turn off ALK and really have transformed outcomes for patients. And yet we still in most patients see this inevitable resistance develop. And so I would say in ALK-positive lung cancer, we've really been focused on understanding how is it that the cancer can come back when we've had such incredibly effective therapies, and what makes up those residual cancer cells that we may not even be able to see, but they are there, they're surviving, and then eventually they grow out.
Yeah. I think you've all captured the opportunity very well, the challenge and the opportunity. There are small numbers of cells. They are there. They are resisting our best efforts to eliminate them. And under certain circumstances, still to be determined, they can come back. And that's the problem we're trying to avoid. And so in thinking about this, you might imagine MRD in different contexts, if you will. You've described it as a biomarker of the disease. I might describe it as a targetable disease state. I'd like to explore that a bit with you. And at that level, it's a clinical decision-making tool. What do we do given this information? What do we do for the patient? So thinking about it in those terms, not just that it exists, but what can we do about it? How are you now thinking about MRD? And please, if you can, think about this in the context of the team labs that you're participating in. How are the teams that you're working with breakthrough cancer approaching the MRD problem now differently? And maybe here I'll start with Jacqueline.
Thank you. And I'll also incorporate one of our Q&A questions, which was, what flow assay do you use? What markers of our interest? So to answer your question, that one of the things that is important, at least in AML, for our disease, I can say is we have to harmonize how we do this. And so we have an imperfect assay that most of us use clinically, and that's a flow-based MRD assay. And one of the strategies we've chosen to approach at Dana-Farber is we send all of our samples to one center that's hematologics, that's available in Seattle. So that way they can process and run the assays. And that allows us to do some comparison since it's on one platform. There's other centers like Sloan Kettering, who is a part of our Breakthrough Cancer Grant, where they're a central lab for our clinical trials. The main thing is it's good to have one site when possible that's reliable with a fast turnaround where you can then do comparisons so you can understand when was this assay reliable and when are there opportunities for improvement. So one is harmonizing, and we think that at least capturing data points is important, especially as we have new therapies rolling out and we're trying to figure out when is the best time to look. I would say in terms of a second problem is trying to interpret or understand how to make these clinically accessible and clinically relevant is when we look at the data from the past, we have seen a couple of things. One, when people are MRD negative with the available tests, about 30% of those patients still relapse, which tells us our assay missed the point. We don't have the best assay, and we sometimes miss leftover disease. And then among the MRD positive cases, similarly, about a third of patients end up being MRD negative and never relapsing. And so that tells us a couple of things. One, we always have to do no harm. Don't treat patients with extra things that otherwise would never have needed it. So that makes us really be thoughtful about, are we obtaining the MRD test at the right time? And also thinking about getting serial time points so we can start to track patterns or kinetics of loss over time, so we can understand how to really interpret it, especially with these new therapies. And secondly, because this is a newer data that we're incorporating, because we actually have more treatments available. I think if you had limited treatment options, it makes using MRD less informative. When we start to have new therapies like we are living with now in AML, which is an incredible time for patients with leukemia, we can now use this assay to really understand what a patient specifically should get based on how they respond. And one of the challenges of AML, much like many of the diseases for my colleagues on the panel, it's a heterogeneous disease. So there is more than one genetic mutation, more than one driver often occurring, making it very difficult to target with just one pill, one approach. And so using this assay as a way to track overall disease burden and what we should consider next.
Yeah. And Alice, in the case of ALK-positive lung cancer, where the treatments to date have been wondrous, and you've been very involved in bringing them to the clinic and to approval, and yet the problem remains that the disease is not gone for too many patients. So how are you beginning to think about MRD as an opportunity to improve the control of the disease in this setting?
Yeah. I mean, I think I absolutely agree that I feel like MRD is now this opportunity that we have to really impact, to further impact and improve, the outcomes for patients. Because as you just said, we already have good therapies, but most patients will face this problem of resistance at some point. It may not. We may have delayed it by quite a bit now with drugs like lorlatinib, for example, which is a third generation ALK inhibitor. But even 5 years, 8 years, 10 years down the road, we may be encountering resistance. And that is because during that period of remission, there were microscopic, viable drug tolerant persisters that eventually did grow out. So I do view it as an opportunity to intervene. So like you said, Tyler, it's a biomarker of potential relapse down the road. It's a disease state. It's a time when the disease is in so-called remission, no actively growing cancer. But I think maybe most importantly, like you were saying, it's really now something we can think of as a tool to really guide our management. And here I think, even though we're focusing on how do you detect it, how do you track it, actually, I think our goal really is to eradicate the residual disease, because if we can eliminate that residual disease, those drug-tolerant persisters, then I think we should be able to hopefully prevent that emergence of resistance and really enhance the chance of cure. And so in our team lab, we're very focused on, I would say, the full spectrum of MRD, from really understanding the biology, like what allows these cells to survive and persist and eventually grow out. How do you detect and track MRD? What's the best ctDNA assay, for example? We don't even know the best assay. We don't know the best timing, et cetera. But I would say a really key goal for our team lab is, how do we assess interventions at the MRD stage? And so right now, we're focused on developing this clinical trial framework across all of our breakthrough cancer sites so that we can robustly test, I would say, both standard and novel approaches that we can bring in at the time of residual disease. And when I say standard, I mean things like radiation therapy, to do focused radiation to try to eradicate at least macroscopic residual disease. But we also want to be able to bring in investigational therapies that could potentially eradicate residual cancer cells. So we're exploring an ALK-specific vaccine and a way to basically try and harness the immune system to try and recognize and eliminate any residual cells. We're also hoping to test other novel approaches to try and counter sort of the growth and the survival of these residual cells, so sort of biological vulnerabilities. And so I think that's a really exciting opportunity, Tyler, that we have to use our breakthrough cancer sites to really test in a robust way if an intervention at the time of MRD can ultimately impact the course of disease.
Yeah, I find it very exciting as a lung cancer researcher myself. Just following the developments in this field has been exciting in the case of our ability to control ALK-positive lung cancer and many oncogene-driven lung cancers. But we're not done. And I think the focus on MRD is exactly the right thing to do. The MRD state is a vulnerable state, at least how I think about it. The disease has changed, and it could well be that we can exploit those vulnerabilities. And I personally like the immunological approaches especially well there. Alice referenced clinical trial thoughts from that team. I want to continue on talking about clinical trials. Amir, I'm going to turn to you now and ask you to address the question I just raised, but do it in the context of the clinical trials that your team is focused on. The second look laparoscopy trial, you've recently published data. You have an ongoing clinical trial focused on MRD and MRD eradication. How is the focus of MRD changing the way you think about what you're doing in the clinic?
Yeah, thanks, Tyler. I think the theme of opportunity definitely is one that our team lab is trying to capitalize on, and the way we're thinking of MRD is both as a starting point. So you may have a patient who's finished frontline treatment, and now they're discovered to have MRD by whatever marker, and so they're in need of a useful treatment. And I definitely agree with Alice. Our goal should be eradication, shouldn't be just monitoring. So that's one population. So MRD as a starting point, And there, we're very interested in the immune system, because if we could harness the power of immune system, you already heard from my co-panelists that one problem is the heterogeneity in cancer. And as clinicians and researchers, that's not something that we can deal with very easily. However, the immune system is used to heterogeneity. It's been evolved to deal with evolving bacteria and viruses over millions of years. And so I think harnessing that power, at least theoretically, is very attractive to us. The second way we think of MRD in terms of our clinical trials, and just to go back to that point of MRD as a starting point, we have now started a clinical trial that's open at MD Anderson and Sloan Kettering, where we're using an effective immunotherapy regimen in ovarian cancer, which is a combination of bevacizumab or Avastin, pembrolizumab, which is an anti-PD-1 immunotherapy, and a low dose of oral chemotherapy pill called Cytoxan. This combination has shown benefit in recurrent ovarian cancer. And in that study, they saw that the benefit was better the less heavily pretreated patients were. So we're introducing it in this opportunity where patients literally have microscopic disease. And so we're hoping that that can provide benefit. The second way we're thinking of MRD is as an endpoint. So what do I mean by that? I mean, if a patient had a treatment and there is MRD left behind, in some ways that leads to the conclusion that the treatment did not completely eradicate the disease. And so can we use MRD as a surrogate endpoint to make clinical trials for promising frontline treatments more feasible, faster, more informative? And we think the answer is yes. So we're doing a pilot study in the frontline treatment of ovarian cancer. Patients are randomized to either getting chemotherapy and surgery alone, or chemotherapy, surgery, and intraperitoneal immunotherapy with a very potent immunotherapy treatment called interleukin-12 or IL-12, which causes tumor inflammation. And one of the problems with getting immunotherapy to work for ovarian cancer is the lack of tumor inflammation, or ovarian cancer being a so-called cold tumor. So we're doing this randomized study, but the unique feature is that the principal endpoint, the primary endpoint of the study, is going to be who has surgical minimal residual disease at the end of that frontline treatment. And of course, patients are going to still be followed until progression, but our hope is that we can then tie the rate of MRD after frontline treatment to long-term benefit with like progression-free survival, which is the current standard endpoint for such trials. The problem with just having progression-free survival is that it takes a very long time to get that information. Patients may not progress for a year and a half, 2.5 years. And so those trials will be much longer to inform. They will be more expensive because they require larger patients. And so we're hoping to use MRD as a surrogate endpoint as part of that clinical trial.
Yeah.
Tyler, can I just build on that, just emphasize one thing in the context of ALK? Because I totally agree with everything you said, Amir, and I would say especially around how important it is for us to be able to use MRD as a surrogate endpoint. And if if you think about ALK-positive lung cancer, I mentioned earlier that our first-line therapy right now is lorlatinib, and actually, Amir, the median progression-free survival with first-line lorlatinib is over 5 years. And so it's really become, in my mind, this critical issue now, because if we want to make more advances in the ALK space, it's going to be really challenging, because if we have to use progression-free survival, PFS, as our primary endpoint, and we know for lorlatinib that exceeds 5 years, we're going to be waiting many, many years to see any benefit of a novel therapy over lorlatinib. And I would say that this could really make drug development in the ALK space stall if we're really limited to just these traditional endpoints of progression-free survival. And so I'm really, really focused on hopefully being able to use MRD as an earlier surrogate endpoint.
Yeah. I think it's an extremely important point, and Jacqueline, I want to come back to you on the same point in the context of AML, but I agree with you both. If we can document the value of the MRD measurements as predicting long-term outcomes or responses, as has been done successfully in multiple myeloma, we can rapidly accelerate the investigation of new drugs, new drug regimens, and hopefully develop more effective treatments more rapidly. So this is a collective goal. So Jacqueline, talk about it from the perspective of AML. You too are engaged in clinical trials, very much focused in the same fashion. Talk a bit more about that.
Yeah, I agree with Alice and Amir. It's been a long desire of us in AML, especially now that we have more therapeutic options available, to look for surrogate markers to overall survival, which remains paramount. But to advance therapies faster for patients, we need something with a shorter turnaround time. We've been more creative lately in the acute myeloid leukemia space, taking a look at things like event-free survival, which is like an MRD conversion time point, as another way for us to try to understand, is there value to an earlier time point, so we could try to introduce drugs that have true signals and efficacy attached to it. We're also looking at the proportion of patients that convert from positive to negative. So in our AML space with the Breakthrough Cancer Collaboration, we have this phenomenal collaboration with our friends at Sloan Kettering, MD Anderson, Hopkins, and MIT. And we have launched 2 clinical trials in AML with the support of Breakthrough Cancer that are novel and have not yet been done. For both of these assays, we're using flow measurable residual disease to get patients onto trials. So they have to have detectable, measurable residual disease that universally everyone would agree with. This is leftover disease. It needs to be addressed. But patients are under remission by eye under the microscope if you were to do a bone marrow biopsy. For these patients, depending on what their genetic mutations are and surface markers are on their leukemia cells, we have 2 clinical trials. One of them is super exciting. It involves a menin inhibitor called revumenib. It was just FDA approved in the last year for patients with KMT2A gene rearrangement, which is a rare subgroup of AML, and for patients with nucleophase 1 mutation, which happens in about 1/3 of patients. Because we know that drug has activity as a single agent, but does not lead to long-term remission on its own, our clinical trial involves combination approaches, and that addresses the heterogeneity issue. So we're partnering it with a drug called venetoclax. It's a BCL2 inhibitor that pushes cells closer to undergoing cell death, and it makes them more vulnerable to chemotherapies or other single agent biologic therapies such as revumenib. So we have a doublet study for patients with leftover MRD that have a history of nucleophase 1 mutation or KMT2A. And our goal is to try to convert them from positive to negative for MRD. And then we'll follow up to see, does that correlate also with overall survival, event-free survival? Similarly, for other patients where we really wanted a study that could have broader reach across more subgroups of patients. On our patients' myeloblasts or leukemia cells, there is a marker called CD123. It's on the surface of the AML cells and also on the early leukemia stem cells. And there is an immunotoxin that's conjugated or bound to diphtheria toxin. And so if you express CD123, this immunotoxin can bind and then drop off or deliver diphtheria toxin. That drug is called tagracifus. And so we have another clinical trial for people that have the CD123 expression, which occurs in over 80% of AML patients. So broader reach for patients that have leftover disease or MRD positivity. And we are combining that with azacitidine venetoclax, which is an approved combination for people with active disease. Our approach with these 2 combination therapies is to try to eradicate and leverage this therapeutic opportunity of leftover disease and try to understand, can this be safely done? We think with the doses we've selected, we can do this based on the available data. And can we convert patients from positive to negative? And if so, for how long? And what other additional MRD assays at a research level could be informative? So with the routine clinical assays, we are simultaneously running research level assays to learn how can we better measure this leftover disease or understand why the drug worked or didn't work in these patients.
Yeah. these are all incredibly important studies and to me extremely exciting. I can envision the future here where the focus will be on getting rid of the last cancer cell, and that's really what you guys are talking about. It won't be easy, and there won't be a one-size-fits-all solution given the heterogeneity of the disease. But this is the area of focus that I think we need to emphasize. Jacqueline, you talked a bit about the other members of your team. I want to ask Alice and Amir to talk about their breakthrough cancer teams and how the nature of those teams is allowing more rapid progress and maybe a different style of science than you're used to. Maybe I'll turn to you first, Alice.
Yeah, well, as I said, I'm a proud member of this team because it's an amazing team that we have across multiple institutions. Many of them have been very, very deep in the ALK space. And I think just as a little bit of background, ALK-positive lung cancer is actually not that common. It's about 4 to 5% of lung cancer. And so if you think about that overall, it's a small, relatively small fraction. And so when you're dealing with a relatively small fraction, of course, numbers really matter. And so here, I think one of the wonderful things about working together in this collaborative way is that we now have multiple institutions all working together and bringing together these ALK-positive patients. And so obviously with more numbers, we can move even faster. But we also have just amazing researchers and clinicians as part of this team. And I would just give a couple examples of where I really think this team is really working and will be able to accelerate research. So for an example, I think one of the limitations in the space of residual disease and ALK-positive lung cancer is really understanding the biology of these drug-tolerant persisters. There have been studies, of course, already done, the various modeling done in the lab, but I actually think we need to really be able to biopsy the residual disease from patients. And in fact, when I think back to all of our studies on resistance over the many, 2 decades, basically, some of the most crucial insights came because we had tissue from patients. It wasn't simply just modeling something in the lab. And so I do think that if we could obtain these on treatment residual biopsies from patients, that would be huge for us. And so, in fact, all of us on our team are working really hard on a whole biospecimen collection. We have protocols in place so that at our individual sites, we can actually be, of course, following and treating our ALK-positive patients. And when appropriate, we can obtain these very, very precious on-treatment biopsies and really go deep now in studying the biology, do full profiling of the residual disease state. And then another example, just my second example before I turn it over to Amir, is I previously mentioned how we are building this clinical trial framework to assess interventions at the time of MRD. And again, I think this is not something a single institution can do. And honestly, even for our team of incredibly talented investigators, I would say it's a challenge to develop a study like this. And so I felt so fortunate to be embedded in this team and to have all these great minds working together. And then, of course, be able to pool the resources, the operational efficiencies of our team, individual institutions within this team, so we can launch this, I would say, pretty groundbreaking clinical trial focused specifically on MRD and ALK-positive patients.
That's wonderful. Amir, I will turn to you, but I'm going to frame my question to you slightly differently. I know that the ovarian MRD team has benefited a lot from data science and analysis of complex circulating tumor DNA signatures. That's another example of how Breakthrough Cancer has tried to invest, in this case, in data science to support all the teams, actually. So talk about the interactions that exist within your team and connect it to the data science effort.
Yeah, I think early in our conversation, we talked about how MRD has to do with the disease state, the cancer cell state, but also the immune environment. I completely agree with what Alice mentioned that, having a biopsy of MRD is super important because it enables us to ask questions that are not just simply positive if you just consider MRD as positive or negative. So our team lab is blessed with having expertise in data science by several different individuals. Linghua Wang is a computational biologist. Saurabh Shah from Sloan Kettering is an expert in a clonal evolution of cancer. Kai Wischerpfennig from Dana-Farber is an expert in immunology. And so with their help, we are trying to look at how is ovarian cancer evolving to reach this resistant state. What are changes in the cancer cells? What are clonal evolution of the cancer cells? But also at the same time, what are the changes in the tumor microenvironment that may be permissive to allow these sanctuary sites where cancer cells can develop and proliferate or lay dormant? And I think the neat thing is we kind of live in a day and age where there are so many exciting tools available to do, to analyze small biopsies. And so I think this is really the perfect time. And, really all of it is enabled by Breakthrough Cancer to be able to get these precious biopsies from clinical trials and look at the tumor environment, look at what's going on in the bloodstream in terms of tracking clonality of the cancer that's changing over time under the selection pressure of chemotherapy and or immunotherapy. So these are some ways where our team is kind of looking at samples that are produced during these trials, but in a really multidisciplinary a way that's really considering multiple hypotheses, in terms of MRD. Maybe it's not just the cancer cells, maybe it's some combination of, sort of nurture and the environment.
Both Alice and Amir referenced deep analysis of patient tissue, patients on study. This is another theme, along with MRD, as another theme of Breakthrough Cancer funded research, where we want to make sure that we learn deeply from every patient and apply the best of science in the clinical context. There's much still to be learned, and it's important that we take full advantage of these precious materials that can be obtained. And sometimes it's costly to do that. Sometimes it's complicated to do that, but we think it's an investment well worth making because we will learn, and by learning, we will go faster. I'm going to turn to questions from the audience in a few minutes, but I want to close our discussion about MRD thinking about technology and its impact on what we can do today. And all of you have referenced circulating tumor DNA or ctDNA, fragments of DNA that are shed from the cancer into the blood and can be tracked. This has been enabled by the genomics revolution more broadly, and it's changing fast. Jacqueline, you talked about sensitivity of assays. The sensitivity of these assays is getting better and better. So where do you see the future, ctDNA and perhaps related technologies, changing what you're able to do, what you're able to see, what you're able to learn? So Jacqueline, I'll start with you.
Yeah, I think that there are so many exciting things about our collaboration that it's really hard to just label a couple things. But I will say, because we have a shared interest with trying to advance the field through the lens of MRD, we're sharing and pooling our resources, including patients on study. And when patients have MRD level disease, that's not that many cells. And so one of the things that we've been trying to understand is, in addition to the routine clinical assays, which have a lot of limitations, are there newer assays, including circulating tumor DNA, that could be used? Now, in a blood cancer like acute myeloid leukemia, that seems like an obvious choice. But one of the things that has been very difficult is trying to distinguish what's noise versus what's going to be clinically significant. So one of our phenomenal collaborators, Lukasz Gondek at Hopkins, has really been a pioneer in this arena for AML. And one of the things that we've been doing to try to understand, does his circulating tumor DNA assay, which is focused on using peripheral blood, which for our patients is tremendous, because even though bone marrow biopsies are much easier to obtain than lung or ovarian tissue, they're still very invasive. And if we're still trying to figure out the right time point and we're collecting multiple blood samples, that's a lot easier than collecting a lot of bone marrow serial samples. And so our collaborator here is trying to focus on using plasma or a portion of the peripheral blood to try to detect leftover DNA that can mirror the signature of the patient's original leukemia. So we can then understand, based on the kinetics of loss or the arrival of new mutations through circulating tumor DNA, when can we act upon this MRD, and are there new treatments that can then be used? So we're pulling together samples from our prospective clinical trials. So they go through one lab, and then they get sent out to all the other labs in our collaboration, which is really fantastic. So that way everyone can study the same patient through their lens at the same time, as opposed to everything existing in one silo, which unfortunately commonly happens when one institution does a trial on their own. So by having experts across the U.S. Take a look at it through their lab expertise and through their technique from these orthogonal approaches, I think we're going to be able to leverage the best technology moving forward. We're also, similar to what Alice mentioned, and I'll just make a plug for it because we put a lot of time into this. We also have a shared biobank as well, where we're actually sharing patient samples from patients that have been consented. So that way we could also, similarly to the clinical trial, from existing sample sets where we know the patient outcome, we're taking a look at paired samples with matched blood and bone marrow to try to understand how to leverage tools like circulating tumor DNA. So we could, instead of just doing bone marrow biopsies, hopefully we'll get to one at some point in the future, using peripheral blood as a way to detect MRD.
Wonderful. And Alice, from the lung cancer perspective, how's technology changing how you think about things?
Yeah, I mean, we've been using ctDNA assays for actually a number of years now to look at, for example, mechanisms of resistance to targeted therapies. This is in patients who are progressing. But I'm actually really excited now that we have newer technologies and tools, much more sensitive ways to assay for ctDNA, so that we can actually now study our MRD. And actually, this is another one of our aims of our team lab, which is to really understand the technologies here. What are the best ctDNA approaches for detecting and quantitating residual disease? Really dive deep into the kinetics of ctDNA as patients are treated with various targeted therapies. How do we really use ctDNA to predict the risk of progression? And ideally, we do that well before clinical signs of progression. And when I think about sort of the future, or maybe the vision for where we could land with all of this research, I can imagine that what we'll want to do in the future is actually incorporate what we now know, we'll find as the most robust, the most sensitive ctDNA assay at the right time in patients who have ALK-positive lung cancer and they're on their TKIs, so that we can detect residual disease. Hopefully that information then can guide our selection of personalized therapies for patients so that we can eradicate that disease. And then hopefully we can use that technology then to continuously monitor patients for the very earliest signs of relapse. So again, with the whole goal of intervening before overt resistance develops.
Right, perfect. And Amir, I'm going to give you the final word. And as you answer the question, maybe you could reference the recently published work from Saurabh, because that's a great example of how ctDNA can be used to inform not just that there is disease, but what's the nature of that disease and how you might be able to deal with it.
Yeah, so I think, again, ctDNA is not one thing either. ctDNA can tell us about minimal residual disease. It can tell us about emerging clones or mutations that might have actionable. And in the paper by Saurabh and his team, they followed patients with ovarian cancer during frontline treatment, and they discovered that some patients were having amplification in areas that, for example, led to increased expression of HER2. Well, there are now antibody drug conjugates that target HER2, and this one of their sort of illustrative cases, a patient was started on that and has been a long-term durable responder to that, probably because it was caught at MRD, sort of early on, and it wasn't somebody who has had recurrent cancer. And that's just an example of how some of the knowledge that's being generated through the support of Breakthrough Cancer can really immediately go into the huge pipeline of novel therapeutics. I mean, you heard that. I think all of us are excited because our cancers for a long time had very few treatments. Now we have this embarrassment of riches where there are a lot of treatments, but we don't yet know how to best and when to best apply these treatments. And I think that's what I look forward to in the future. And I think that the technology evolving, I agree. You know, in our business, we can compare surgery result with ctDNA results. So we have an independent way of kind of looking at ctDNA, and some of the first generation ctDNA assays that look for variants based on whole exome sequencing, we found that would pick up about half of the MRD that we could pick up surgically. And some of the newer generation circulating tumor DNA assays that are using whole genome sequencing, so a lot more variants and therefore higher sensitivity, are now kind of you know, they're competing with surgery in terms of accuracy. And of course, surgery is not 100% either. And so we still need better ways. But I think it's exciting because I think some of the ctDNA technology is approaching sensitivity of surgery. And of course, they have the advantage that we can do them serially. We can't operate on patients serially. So.
And it'll only get better and better. And
Yeah.
you all will learn from each other. And across the Breakthrough Cancer Network and within cancer research collectively, we're always going to get better and better. We're going to close with a couple of questions from our audience, and I'll just read them out and then ask you all to respond. So we've talked about MRD and whether or not it will be a validated clinical trial endpoint. I think in multiple myeloma that is already true. When will we be there in your estimation for AML or lung cancer or ovarian cancer? So Jacqueline, I'll start with you. And I'm not going to hold you to this answer, but when do you think?
Well, I think that MRD, there's a lot of attention being placed on it more than ever before. My colleague Coleman Lindsley has been working really hard with the NIH Foundation to try to move this forward. So I do think that there is a collective effort, and I'm thinking that in a couple of years, we will be able to have MRD, at least for some AML subgroups, a bona fide endpoint, something that will be recognized by the FDA as a target. For the majority of patients that have heterogeneous disease, I think that's going to remain a challenge of whether or not there should just be a single assay. I suspect that we're going to move away from a single assay, and there will be patient-specific assays that will develop probably in the order of years, probably before a decade. We have so many people paying attention to it now. I do think this is something that's actionable and hopefully will meet regulatory attention.
Yeah. Similar view, Alice?
Yeah, I mean, I think that I was really, really encouraged by the in myeloma, FDA, ODAC really unanimously saying that you know, that MRD should be is a valid surrogate endpoint. So I think that's a huge step in the right direction. We have a lot of work to do on the lung cancer side, but I would say, like Jacqueline was saying, I mean, it's a collective effort, right? There are many studies ongoing. And I think, as you mentioned as well, Tyler, it really is on us to ensure that, you know, to validate it, we really have to be certain of the predictive value of ctDNA in predicting the long-term outcomes, right? So I think that takes time. And so, yeah, I would say on the order, we're talking about years, but, you know, 5 to 10 year type of time frame.
And Amir, your view?
Yeah, I think 5 years. You know, maybe I'm a little more optimistic. I think the FDA has drafted a white paper in support of MRD as a surrogate endpoint, as long as there are studies that basically look at both MRD and connect it to more traditional endpoints. And I think this is where, you know, I think Breakthrough Cancer is, you know, funding of pilot studies that kind of show the feasibility. That's going to attract a lot of attention. Once we get big pharma to kind of buy into it, then they're going to be incorporating, you know, MRD assays as part of their tests, and many are already doing that. So I think that data is coming. And I think, the regulators are open to that. So I'm pretty optimistic.
I'll ask one last question and we'll have to go quickly because we're running out of time. But it is true today, as one person asked, that MRD is not routine. It's not routine clinical care. There are barriers to its use. When will it become more broadly adopted? I know in your centers you use it routinely, but what about for the average individual out in the community? Amir.
Do you want me to? Okay, so first of all, Centers for Medicare and Medicaid has approved MRD for certain indication, for at least a certain ctDNA assays. So there are commercial assays that are, for example, approved for monitoring patients on immune checkpoint inhibitors. Immune checkpoint inhibitors is a big market in the US, right? There's like 14 or 18 different indications. So, so I think there are a lot of, indications that, and once Medicare covers it, other third-party payers cover it. And I think some of the ctDNA companies are also being strategic. They are kind of promising that if an insurance doesn't cover it, they're not going to charge patients. And so they are trying to help with early adoption. And our group has been definitely early adopters, but I think now there are certain Medicare approval rules that are paving the road for more broader adoption.
Yeah, I think we'll close it there. I would agree that the kind of science that you're hearing about today, the kind of progress that you're hearing about today, will lead to greater and greater adoption. There will be pressure to use this everywhere because it just frankly makes sense. And then the clinical applications will become even more prevalent. I want to thank the panelists today. That was a really fun discussion on a really important topic. I actually learned a lot in talking to you, so I very much appreciate your time. And thank you to the audience for joining us today. And please tune in to the next edition of Breaking Through. Take care, everybody.